Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes and Lecture. So, in the previous two videos, we have discussed the clinical case scenarios regarding the management of hypothyroidism in young as well as pregnant and elderly patients. So, today we will discuss about the management of hyperthyroidism. Okay. So, let's begin with the name of management, meaning clinical case scenarios. So, let's begin with the name of Almighty. So see here, he has a patient who is 26-year-old non-pregnant female. This is important, okay? Non-pregnant female, and she has a new onset of Graves' disease. So she had symptoms of weight loss. She had a thyroid swelling, tremors, okay, heat intolerance. All these symptoms she had. So tests were ordered. So her TFT profile is there is increased free T4 with total T3 and decreased TSH. So this is overt hyperthyroidism. Now she is also positive for TRAB, thyroid receptor antibody. So that means the cause is Graves' disease. She has goiter, diffuse and mild tachycardia. Okay. So baseline labs, what we should do? We should do thyroid function test. TRAB we should do. Why we should do TRAB? Because at baseline it is very important to confirm that it is due to Graves' disease. And second important point about TRAB is, so after 12 to 18 months of this anti-thyroid therapy, if this TRAB they have a role. If TRAB again, if the TRABs are checked, thyroid receptor antibodies are checked, if they are negative, then it is very less likely that the patient may relapse. Or if they are positive, then it is more likely, 80% of chances, that the patient may relapse after the discontinuation of anti-thyroid drugs after 12 to 18 months. So remember, in Graves' disease, after 12 to 18 months of therapy, 50% will remit and 50% will relapse. So we'll discontinue after 12 to 18 months. When we will discontinue? So first we will do here TRAB again after 18 months. If TRAB is negative, then we will discontinue the drug, discontinue the anti-thyroid drug, particularly methimazole, commonly methimazole. And if it is positive, this TRAB is positive, then we will continue for one more year, and then again we will measure this TRAB after one more year. Again we will take decision depending on positive or negative. So positive meaning more than 80% the patient will relapse. Negative meaning there are less chances of relapse. Even then we will monitor these cases also where the TRAB is negative for first month, second month, third month and 6th month, then every 6 months for life. So this is the roadmap how we manage a patient of non-pregnant Graves' disease. Okay, we should remember this. Okay, so we have already here thyroid function test, antibodies, and this is also important, CBC and LFT. These are baseline because these anti-thyroid drugs, what they will do, they will cause agranulocytosis and hepatitis, acute hepatitis. So for knowing that, we should have a baseline CBC and LFTs. So first we will give a symptomatic control by beta blockers. So we can choose either propanol or a beta cyclic blocker like atenolol or metoprolol. The dosage is 10 to 40 mg, atenolol 25 to 50 mg. If you are going propanol, immediate release, you should give it in TID dose, and if you are going atenolol, you should give this in OD dose because this is long acting. So why we are giving this? To control the peripheral symptoms, adrenergic symptoms. So along with this, we will give anti-thyroid drug. Okay, so because the patient is non-pregnant female, so we'll give methimazole as a drug of choice. If the patient was pregnant, then in the first trimester, methimazole is contraindicated because of fetal malformations, then there we will give propyl thiouracil, but here it is not the case, so we'll give methimazole. Okay. And previously carbimazole was very much prescribed, but it is now less prescribed because this has a high risk of hepatotoxicity, whereas methimazole has low risk of severe hepatotoxicity. Now how you will dose? So you will dose according to the dosage of ft4 levels. See here, if the dosage, if the elevation of free T4 is 1 to 1.5 times of the upper normal limit, that the MMI, meaning methimazole dose, is 5 to 10 mg per day. If the dosage of the elevation is 1.5 to 2 times the upper limit of the normal, then the dosage is 10 to 20 mg per day. If it is more than 2 to 3 times upper limit of the normal, then the dosage is 20 to 30 mg. And remember, when the dosage goes to 20 mg, 20 to 30 mg, you should split the dose. For example, if the patient needs 20 mg, you will give 10 morning, 10 evening. If he or she needs 30 mg, then you should give 10 morning, 10 afternoon, and 10 evening, like that. Okay. So like that we will prescribe, and we will counsel the patient about agranulocytosis, hepatotoxicity, and if pregnant, for teratogenicity, or not pregnant also, non-pregnant females who are married, so we should counsel about pregnancy. So if they develop sudden fever or sore throat or mouth sores, then they should be counseled that they should come immediately to the clinic or hospital, and immediately CBC should be ordered to look out for agranulocytosis. If the patient develops jaundice, dark urine, or acholic stools, meaning white stools, okay, so then also we should suspect hepatotoxicity, and the patient will have nausea, loss of appetite, these things will be there. So there you should order LFTs. Teratogenicity. So female patients should be counseled to have proper contraception, because, and they should have planned pregnancy, because if they are planning pregnancy, then the drug should be changed from methimazole to MMI to PTU in the first trimester. Okay, because methimazole is will cause 3 types of anomalies mainly, that is one is anomalies aplasia cutis, a condition of skin; choanal atresia, a condition of posterior nasal cavities, choanal atresia. Okay. Third is tracheoesophageal fistula. So these things can the fetus can develop in the womb of the mother, so that we should counsel. Okay, she should have a planned pregnancy, and if she doesn't want, then she should have a proper contraceptive method. Okay, so like that we should start. Now we should adjust the dosage of this methimazole depending upon the level of free T4 levels, depending upon FT4 levels, because TSH levels, they will take months to come back to normal. So later we can use TSH levels also, but it will take months to come back to normal. So initially we'll see depending on FT4 levels, we will titrate the dosage. So we'll order free T4 and total T3. So for example, now after 1 month, meaning after 4 to 6 weeks, or 1 month, after 1 month, if we should advise the patient to come for follow-up, and we should order free T4, and if at that time, if T4 is normalizing, meaning the levels are downtrending or normalized, one is normalizing and one is normalized, then we should decrease the dose by 30 to 50% dose, and usually it will be 5 mg. Okay, we should decrease the dose by 50%, 30 to 50%. Why? What is the reason behind that? Continuing high initial dose will rapidly push the patient into iatrogenic hypothyroidism. That's why. Okay, now this is one condition, normalizing or normal became normal. Second condition is remain elevated, so they do not come down. Then what you should do, maintain the current dose of methimazole, and ensure ask the patient whether she or he is taking the medication properly or not, and again recheck the labs in 4 weeks. See here, one point to note, here it is not given that to increase the dosage. Okay, here it is given to continue the current dosage. Okay, This is point to be noted. Current dosage should be continued. Now, if the TSH is normalizing or normalized, then discontinue the beta blocker step by step, because if you discontinue abruptly, then there will be a withdrawal syndrome because of these beta blockers. Then you should taper gradually when the resting heart rate normalizes and the patient becomes asymptomatic. Come to the maintenance phase. So after 3 months, okay, again check T4, free T4, not only T4, free T4, TSH levels. Okay. One important word is, I said this one, the TSH will eventually wake up and normalize. Once TSH is unsuppressed, it becomes a reliable marker alongside free T4. Maintenance dosing. So maintenance dosing will be, so goal is to keep the patient euthyroid on lowest possible dose. So usually it will be 2.5 to 10 mg daily. Now if the patient becomes hypothyroid, okay, elevate TSH and low free T4, then reduce the methimazole dose. Okay. And there was initially talking that you can use two methods for this. Either you can give high dose of anti-thyroid drugs, then you gradually taper. That was one method. Second method is you totally block the function of the thyroid by giving high dose of anti-thyroid and replace it with your levothyroxine. So nowadays, currently the guidelines say that don't use this block and replace method. Okay. So you should replace, decrease the MMI dose. Okay. And you should take it to 2.5 to 10. This is the usual maintenance dose. And check every 3 months or 6 months the TSH and FT4 levels of the patient. Again, one important point here is monitor for side effects. Along with that, monitor for side effects. So if the educate the patient to report if he develops fever or sore throat and mouth sores, jaundice or dark urine or pale stools. If any of the above is present, then stop MMI and seek immediate medical evaluation. CBCs and LFT should be performed in this patient. Now, assessment of remission. So now the patient has covered the journey. Okay. And she was on the maintenance dose for 12 to 18 months. So the 18th month mark is important, because 50% will remit and 50% will relapse. This is important. So how you will assess the probability? By seeing the thyroid receptor antibody levels. So if the thyroid receptor antibody levels are negative, then high chance of remission. Discontinue methimazole. If thyroid receptor antibodies are positive, then high chance of relapse, often more than 80%. Then continue low dose methimazole for another 12 months. That is one option. Second option is take definitive therapy, either in the form of radioactive therapy or thyroidectomy, depending upon the condition of the patient. Okay, and condition of the thyroid. So that's the thing. Now, even after discontinuing, so this is discontinuation. Even after discontinuing, monitor the patient. Okay, surveillance should be done at first month, second month, third month, then 6 months, then every 6 to 12 months for life. Okay. So if the patient relapses, what you will do? If the patient relapses, again there will be 3 options. Resume the anti-thyroid drugs, or patient can take radioactive ablation, or patient can undergo surgery, depending upon the thyroid status and depending upon the patient options. Key takeaways here are: methimazole is the first line in non-pregnant patients. Titrate dose using 3 T4 levels, not TSH. Use the lowest dose that keeps the patient euthyroid. Assess TRAB at 12 to 18 months to guide discontinuation. Close monitoring after stopping ATD is essential to detect relapse early. Okay, for life. And if he or she relapses, better he or she should go radioactive iodine therapy or surgery. But if she doesn't, then you should continue the antithyroids for life. Okay, that was the first case of Graves' disease, hyperthyroidism due to Graves' disease. Now, there is something known as subclinical hyperthyroidism. This is very important. Okay. So see here is a patient who she is 68-year-old female with TSH less than 0.1, but normal free T4 and total T3. So this is subclinical hyperthyroidism. Why should we treat these kind of patients? Okay, why should we treat? Because these kind of patients are at high risk of fatal fibrillation and they're high risk of osteoporosis and fractures. So in this patient, she is 68-year-old and subclinical hyperthyroid, TSH is less than 0.1, and it is confirmed, this is important, by taking the samples 3 months apart. This is important. So you should confirm this subclinical hyperthyroidism. So by checking the sample, take one more sample 3 months later on. So etiology was established as mild Graves' disease because the patient was TRAB positive, or it can be some nodule or MNG type can be there on ultrasonography or radioactive iodine uptake, RAIU. Okay, so any patient with hyperthyroidism, always scan for sonography for thyroid, very important. Okay, now baseline assessment and whether to treat or watch decision. So first confirm the endogenous etiology. Okay, whether rule out whether it was a patient who was hypothyroid and she was taking levothyroxine excessively. So that is iatrogenic hyperthyroidism. So there, that is not endogenous. Whether patient is taking concomitant biotin for some hair and skin problem. So what happens, the thing which happens, already we have learned, biotin interferes with the kits and falsely they will show hyperthyroid picture. So that should be discontinued, and again the test should be repeated. Iodinated contrast recently for any angiography, like think if the patient has undergone, then one thing we should a ill thyroid, what it will take excessive iodine and it will secrete excessive thyroid hormones, that is jod based effect. So that will cause hyperthyroidism. Okay, for temporarily it happens. So these things we should know, these three things, whether the patient is taking levothyroxine for excessively or whether she is taking for weight loss. Some female take it for weight loss, and secondly whether she is using biotin, and fourthly whether iodinated contrast was used. Now get a baseline ECG and baseline DEXA scan. This is for osteoporosis and this is for AF. Okay, now you can classify according to TSH grade this as mild and suppressed. Mild, you call it as when the levels of TSH are between 0.1 to 0.3. So there, treatment is generally reserved. Treatment is given in this range for patients who are aged more than 65 years, who are having cardiac disease, who is having osteoporosis, and who is having clinically hyperthyroid symptoms. So these patients should receive therapy in this range. Now if it is less than 0.1, then all patients who are aged more than 6 or equal to 65 years should receive therapy, and consider therapy for younger patients with comorbidities or symptoms. So one important point is, in clinical hyperthyroidism we treat the TSH, not the symptoms or normal hormone levels. Okay, TSH should be treated in subclinical, whereas FT4 is treated in overt hyperthyroidism, Graves' disease. Okay, now titration of therapy. First, symptomatic control should be given a beta blocker like cardiac at low dose 25 mg or metoprolol or ethanol should be given even with normal free T4, because of increased sensitivity, patient is at risk of AF. That's why. Okay, then start the anti-thyroid drug of choice is methimazole, because the patient is not elderly. Here the case is elderly and not non-pregnant. So but there is a difference. There we start depending upon the level of FT4, and it can be 5 to 10, 10 to 20 or 20 to 30. So this much of high dosage is not used here. The dose is practically it is 2.5 to 5 mg once daily. That's all, 2.5 to 5 mg. Okay, now one thing to note is, if etiology is TMG or toxic adenoma, definitive therapy with radioactive iodine or surgery is often preferred over lifelong ATDs. Low dose MMI can be used to normalize TSH prior to radioactive iodine or as long-term management if definitive therapy is contraindicated. Okay, that's why sonography of thyroid gland is also important in patients with hyperthyroidism. Okay, so our goal is to normalize the TSH without lowering free T4 and T3. This is very important. So there is a risk of over treatment. You should counsel the patient for symptoms of hypo or hypothyroidism particularly. Okay, fatigue, weight gain, cold intolerance, and lifelong follow-up and lab monitoring is essential if the patient wants TSH. And even if the patient undergoes surgery or radioactive iodine therapy, So she should be what you call monitored for 1 year at least, because more than at least 80% of cases of radioactive iodine therapy, they will develop eventually hypothyroidism. They will require levothyroxine therapy. Now weeks after 1 month, or you can say week 4 to 6 weeks, so we'll do TSH, free T4, total T3. So here we will see TSH value. Okay, that is the managing point. Okay, now what will be the goal of TSH? The goal will be to keep the TSH 0.5 to 2. This in this range the goal should be there. Now if TSH normalizes, meaning it is between 0.5 to 2 and FT4 and T3 remain normal, they are not going up, then maintain the current micro dosage. If TSH remains suppressed, meaning the low dose is not working, then increase the dose slightly by 2.5 mg, you can say. Okay, now if free T4 drops below normal, okay, meaning the patient is now being pushed into hypothyroidism, then either stop or significantly reduce the dose of methimazole, because patient was over treated. Okay, so these points should be remembered. Okay, now come to the maintenance phase. After 3 months, so you will monitor for 1 month, first month, second month, then after 3 months. So if once the TSH is stable between 0.5 to 2, then you can monitor every 3 to 6 months, and then eventually every 6 to 12 months. Maintenance dose is usually 2.5 mg, very low. Patients often require extremely low doses to maintain euthyroidism, sometimes as little as 2.5 mg every other day, alternate day. Continuous vigilance is required to prevent overt hyperthyroidism and iatrogenic hypothyroidism. Okay, so this is same as your hypothyroid therapy. Their weight loss should be seen 10%, more than 10%, less than 10%, and also symptoms of under treatment, over treatment. That is same. Four things should be seen in these patients also. Now long-term strategy: if etiology is Graves' disease, continue for 18 months, then you wean if TRAB is negative, and the protocol will be similar to the Graves protocol. Now if the etiology is toxic multirenal goiter or toxic adenoma, spontaneous remission is extremely rare. So patient either need to take low dose ATD, or better she should go surgery or radioactive iodine therapy. Okay, now what are the key takeaway points? Treat older patients more than 65 years with TSH less than 0.1 to reduce the risk of AF and osteoporosis. Even if they have the level between 0.1 to 0.3, then also you should treat these elderly patients. Use very low dose methimazole like 2.5 to 5 mg, because the hormone levels are already normal. Monitor TSH primarily and titrate it gently to the normal range. Lifelong monitoring is key for safety and optimal outcomes. So that's today. That's enough for today, and we'll discuss thyroid storm and thyroid hyperthyroidism pregnancy management in the next video. Thank you.